Okay, so we know that in CBD there is significant cognitive impairment from the literature that I've read, and that makes sense because we know that there's a significant overlap with frontal-temporal dementia. So, more so than PSP, but because we know that there's behaviour and language variants in CBD that can occur as well as in frontal-temporal dementia. So you can have predominantly a language presentation where you have non-fluent speech, a loss of grammar, your speech becomes halted, non-fluent, or you can have behavioural presentation. So you can be socially inappropriate, there might be severe personality changes, and really, I guess, devastating behavioural difficulties that may predominate that clinical picture. And obviously we get more generalised cognitive impairment because we know that in CBD there's subcortical and cortical involvement, predominantly of the frontal and frontoparietal regions, and that generation expands, so that extends. So you get a greater area of atrophy throughout the cortex as the disease progresses. And the impairments, as I've mentioned, are due to extensive frontal and frontoparietal involvement, as well as some of the basal areas of the brain. Okay, so I guess cognitively, look again, executive, because we've been talking about the frontal regions. We've also got apraxias because of some of the parietal involvement. And what we have in this instance, there's literature to suggest that memory is actually affected. So there is involvement of the temporal lobe. So people with CBD can get forgetfulness, which has been documented in the literature. Now, but what is, I guess, one of the distinguishing factors neuropsychologically is that these people get profound visual, spatial or visual constructional difficulties that you wouldn't see in the other disorders that we've been talking about. And these can actually help to distinguish CBD from other disorders in a cognitive sense. And behavioural difficulties similar to frontal-temporal dementia, disinhibition. So I guess, a good example of disinhibited behaviour, if you're not already aware of it, is that I think someone said to me, look, I get an idea in my head or a thought in my head, and often we have thoughts that we don't really want everyone to know about, that they have a thought in their head and it's out of their mouth before they've even realised what's happening. Because that inhibition mechanism, or the gatekeeper, the social gatekeeper that we have that kind of keeps what we think that we know is not appropriate to talk about from coming out. So that patient was really, it was someone who was really high functioning, was really able to articulate that really well. So it's not a purposeful act to be socially inappropriate, but it just happens. Okay, so that gatekeeping mechanism doesn't work so well. And people obviously have poor insight, so just a poor awareness of the changes that they're having. And if someone, if you're explaining to someone the type of difficulties that they may be having, and you know that they're having them, and they say, no, I'm fine. No, I'm fine, there's no issue. Well, that's obviously a really challenge. That's a big challenge when you're trying to work with somebody or educate somebody or work with carers, and particularly working with the patient can be very challenging if they're not admitting that they need any assistance. And I'm sure everyone's experienced that at some time. We did just run over a bit about the language changes that can occur in CBD, so really the progressive non-fluent aphasia. And so we can have the word finding and naming, and really the expressive language difficulties are really striking. With preserved comprehension, or relatively preserved comprehension, at least in the early stages. And there can be reading difficulties, abilities performing anything to do with numerical information, and also there can be really flat, emotionless speech, so people may speak in a monotone. Okay, so really that was, I guess, trying to identify some of the commonalities that we see between these three different disorders that we're talking about. What type of behaviour and cognitive changes that we might expect. Now, just really, the other issue is too, I guess, from a neuropsychologist point of view, people often say, well, how do we know that if it's a cognitive issue, what do you look for? And I guess I just wanted to share that with everyone here, and I'm sure a lot of you know these things, but I just like to run through it anyway. So I guess, I've had people report to me when we're talking about slow thinking that, thinking takes longer and it's harder. It's like thinking through mud, or the information just doesn't go in. You know, I used to love reading, and I read this sentence and I read this paragraph over and over, and the next day I still can't remember it. You know, I can't do it. But it's not that, I mean, that can happen to all of us, but it's when it's a really big, consistent change that we need to worry about. And when it worries the person, it can be an issue. You know, and I guess the other thing too is that when you're thinking harder all the time, it takes a lot more effort. Thinking's more effortful. And when you're thinking harder all the time to try and keep up with, you know, everybody else, it can be really fatiguing, and people can get really overloaded by that as well. People can have difficulty multitasking. So for those of us who try and make phone calls and check our emails as well, you know, people have said, well, I used to be able to do that and I just can't do that now. You know, I'm working on my computer and the phone rings, and if the phone rings, that's it. I'm distracted, and I really struggle to go back to the tasks that I was doing. People may have difficulty staying on track in conversations, so you might find that you're talking to someone about one particular topic, and all of a sudden, before you know it, even as the health professional or therapist, they're talking about something else, and you have to take a step back and think, hold on, how did we get there? And you know, you can often tell some people won't be able to get back on track, and other people, if you prompt them, they will be able to get themselves back on track. Okay, so that's that kind of attentional distractibility, not being able to stay on topic and jumping around in conversation. It's a bit of an indication that there's something going on executively, that people are having trouble organising their thoughts, essentially. And we talked about difficulty learning new things, so taking on board new procedures at work. You know, when people try and introduce new policies or procedures, people can often struggle to take those on board and learn those. And we've talked about the inconsistent or unreliable memory. And I guess, and David just touched on this, and this is something that you know, I think is really important for everybody to be aware of, is that inconsistency is really a core feature of these type, you know, of any type of progressive neurological disorder, because our brain is our brain is trying to, I guess, make new connections to try and, you know, minimise the impact of what we're, of the difficulties that we're having, but it's not always possible. So, and there's also issues like fatigue, irritability, that can also impact on how we're able to perform things, and it can vary from day to day. And motivation, particularly in these atypical Parkinsonian symptoms, if we lose motivation and people aren't motivated or aren't able to be engaged, then that's, you know, in terms of their cognitive functioning or the way of their behaviour, you know, if you can actually push them above the threshold to get them engaged, then you might actually be able to see what they're capable of. But until people are amotivated and they're not really engaging with you, then, you know, that's not necessarily an indication of where they're able to be all the time. And it can often be tricky, especially when you come to see somebody and they might be sitting in a chair and not really doing too much. It's really about working out what will push them over the threshold to get them motivated, so then you can really see what's going on cognitively for the person.